Okay. Let's see. So single position spine surgery is not a new concept. We've been doing this all this long. It is basically 360-degree fusion surgery without having to change the position. PLIF and TLIF, they are all single position spine surgeries. The advantage of this procedure is obvious. You don't need to flip the patient after interbody work, and it is time and resource efficient, and it's less hassle to schedule the procedure because you don't have to rely on excess surgeons. Then why does anybody still do LLIF and PSF? Well, despite this procedure is inefficient, there are some advantages. And with the LLIF procedure, there's less neurological complication as the cauda equina is not manipulated, and there's large bone implant contact surface, which creates a very stable environment for the fusion. And because you can put a very large implant between the vertebral bodies, you can have indirect decompression with the ligamental texas as well. Because you are putting a large implant, and the deformity correction is going to be much better as well.
Sean?
Yeah, I'm trying to go to the next slide.
Dr. King, we can't hear you.
Can you hear me okay now?
Yeah, we can hear you.
Okay, great. Okay.
So I
Then
think lower left, if you click on there, there should be some symbols that show up, and it will show you. There we go.
There you
got
go.
it. Yeah, there we go.
All right. Sorry about that. And we discovered lateral lumbar interbody fusion surgery, OLIF procedure. It is MI's procedure where decompression of spinal canal and the reduction of the spinal deformity is achieved with the ligamental texas and facet distraction through a transverse approach. Cauda equina is not manipulated during these procedures, and then you can put a very large implant in between. This large bone implant contact surfaces create a stable environment to facilitate the fusion, and non-union is rare with LLIF procedures. And implant placement is done on the ring apophysis, the strongest part of the vertebral body, and there's going to be less subsidence of the graft and better deformity correction with a fewer fused segment. So this is some of the example of indirect decompression with lateral lumbar interbody fusion surgeries. So LLIF has all the advantage of the LLIF procedures, and most importantly, procedures being done in lateral decubitus position, and which leaves the posterior aspect of spine accessible without having to reposition the spine surgery. So LLIF is the beginning of the new modern sense of SPS. LLIF, however, is not a perfect procedure, and you are performing the procedure in the middle of the lumbar plexus, and there can be a lumbar plexus injury, big and small, and the difficulty access to the L4-5 could not be addressed, and you cannot access L5-S1 with LLIF procedures. And OLIF came along is Ante-psoas approach. It has all the advantage of the LLIF procedures, and it addresses the concern of the lumbar plexus injury, and it addresses L4-5 access problem, and you can also access L5-S1 as well. You position the patient in a lateral decubitus position, and you perform anterolateral lumbar interbody decompression and arthrodesis, and you go behind, and you perform pedicle screw fixation. This procedure only takes about 90 minutes to perform. So the advantage of the OLIF procedure plus posterior spinal fusion SPS over the TLIF and the PSF is you can do indirect decompression of the spinal canal without laminectomy, and there's not going to be a cauda equina manipulation. You can place very large implants, so their interbody contact surface is much larger, and there's a less graft subsidence, better deformity correction with the shorter fusion segments. OLIF plus PSF SPS advantage over the LLIF plus PSF is lumbar plexus is avoided. High iliac crest for L4-5 is not a problem. L5-S1 is also accessible. So this is SPS that I advocate. I just showed you a single level, one level unilateral instrumentation SPS, but you can do these procedures for 2 level and 3 levels as well. I believe surgery should be safe, efficient, and fun. When I do SPS, I keep this in mind. For a single level OLIF plus PSF between the L2 to L5, if I were to flip the patient, it normally takes about 125 minutes. If I do SPS without the flip, it'll only take 100 minutes. The efficiency comes from save time from anterior closure because your assistant can do the closing while you are doing the PSF with the PPS in the back. And the time saved from not having to flip the patient, which takes about half an hour normally, even the most efficient centers. Notice, however, PPS takes longer with SPS. This inefficiency is due to challenge in ergonomics. Dependent side of the tissue bunches up, and it makes it placing pedicle screws quite difficult in bottom-up position. So net efficiency is about 20%. For a single level OLIF plus PSF for the L5S1, if I were to flip the patient, it normally takes about 150 minutes. It is because L5S1 dissection is more complex and it takes longer time to close the incision as well. If I do SPS without the flip, it'll take 120 minutes with the same net efficiency of the 20%. Again, you save time by not having to close the incision yourself and by not having to flip the patient in the middle of the procedure. For two-level OLIF and PSF between L2 to L5, with the flipping the patient, it takes about 160 minutes. With the SPS without the flip, it'll take 140 minutes with a diminishing net efficiency of 12.5%. The decreased efficiency is not only due to ergonomic challenge of having to put a dependent row screws from bottom up, but also having to manipulate the rods into them. And there's a lot of soft tissue. It becomes increasingly difficult. And these difficulties start costing the time saved from anterior closure and flipping. So these ergonomic challenges start chipping away the net efficiency. If I do two-level OLIF plus posterior spinal fusion, including L5S1 with flip, it'll take 220 minutes. Again, because L5S1 dissection is more complex, now I have to close 2 incisions. With SPS without the flip, it'll take 185 minutes with a 16% net efficiency. This increased efficiency is due to not having to close 2 incisions in the front and your assistant's closing for you. If I do 3-level OLIF and posterior spinal fusion is L2 to L5, if I flip the patient, it takes 195 minutes. But if I do SPS without the flipping, it'll take me 190 minutes with the paltry time saving of 5 minutes and a significantly diminished net efficiency of 2.5%. The inefficiency is due to ergonomic challenges of placing screws in lateral position, especially bottom rows, and having to manipulate the rod into the screws. They overshadow efficiency you gain from skin closure and the flipping. If I do 3 levels of OLIF and a PSF over L3 to S1, with the flip, it takes 255 minutes. With SPS, it takes 235 minutes with a net efficiency of 7.8%. This relatively increased efficiency is due to not having to close the 2 incisions in the front. And again, your assistant can close them while you're doing a PPS in the back. So with SPS, the time-saving steps are from anterior incision closure and flipping the patient. And time-consuming step is a PPS, percutaneous pedicle screw fixation, placement, and the rod manipulation. So how about we lessen the time-consuming step? For 1 to 2 level OLIF, my experience tells me that the unilateral PPS placement is just as effective as a bilateral PPS. It is because the implant that I use for OLIF has a very large contact surfaces, and supporting OLIF with the PPS unilateral seems to be efficient. The analogy is when we do 1 to 2 levels ACDF, we just do anterior instrumentation. For 3 levels above OLIF, bilateral instrumentation is preferable to have a better stability, just like we supplement 3+ level ACDF with a posterior cervical fusion. So by doing unilateral PPS for 1 to 2 levels, we can decrease the time-consuming steps significantly while enjoying the efficiency from not having to close anterior skin and not having to flip the patient. Here are some of the examples, and you can do L5S1 single level, SPS with unilateral PPS for lumbar spondylolisthesis. This procedure takes 90 minutes as opposed to 135 minutes without having without flipping that patient. You're about 33% efficient. You can also do L4S1, 2-level SPS with a unilateral PPS for lumbar spinal stenosis. This procedure takes 150 minutes as opposed to 205 minutes because you don't have to flip the patient. So is time saving the 30 minutes to 40 minutes that important? You know, you waste your time 30 minutes to 40 minutes every day. But common sense says so, because at 30 minutes, 40 minutes is inside of the operating room. And when you lessen the 30 to 40 minutes of the general anesthetic exposure to the people, and the patients can have less physiologic stress, which is very important to elderly populations. It can make a difference between patients staying in the hospital 23-hour observation unit as opposed to staying in the hospital many days. And it can make a difference between patients going home and going to a sniff. And when you're saving 30 to 40 minutes for each case, you can complete the third case of the day with a regular crew rather than having to work a temporary crew. So it's a safer procedure. And also it's a resource saving. So the value of the saving 30 to 40 minutes in the operating room is a lot more than saving 30 to 40 minutes of a surgeon's time. However, there's a diminishing return with the multi-levels. And if you try to do 3 levels, there's kind of a lot of ergonomic challenge for PPS. And the unilateral instrumentation is not going to give you enough stability, so you end up doing bilateral instrumentations. And it is not just the pedicle screw placement, the rod placement. You try to thread the rod into a 4 screws, top and the bottom. It's not very pleasant. It's not very fun to do. So I think SPS is here to stay, but it is important for us to use a common sense approach. But remember, the core value of the SPS is efficiency. So I recommend do the SPS up to 2 levels for maximum efficiency. If you have to do more than 2 levels, 3 levels and up, I think it's better that you flip the patient. Some additional thoughts. Nowadays, the prone-lateral approach seems to be gaining on a momentum. And to me, you're undermining a more important part of the procedure for the sake of making a PPS easier to perform. And you exchanging one challenge for another. And you try to do a lumbar interbody fusion patient in prone position. It's just not fun. Navigation robotics, they can make surgery easier and possibly safer too. However, I don't think there's any significant advantage over flipping. Rod placement is still going to be challenging whether you use a navigation or robotic robots. And I think there's a utility for surgery for 3+ levels of fusion, but additional setup time of the robots and the navigation makes it less efficient for 1 to 2 levels of surgery. Simultaneously, SPS, one surgeon performing OLIF procedure in the front and another surgeon performing a percutaneous pedicle screw fixation in the back. In order to do that, now you almost have to have technology, either navigation or robots, but 2 guys working at the same time, it's just not very fun. So I don't recommend that. Thank you.